There was a recent piece in the Rutland Herald describing what the University of Vermont Medical Center is planning to do, and that is they are looking to change their method of being paid by Medicare and Medicaid, I gather. And that is they're reaching out to their patients to keep them healthy as opposed to being paid for providing services. And it's a whole change of philosophy, obviously a major economic change. Is that something that's going to come down here one day?
It's coming down here as we speak.
Okay, then.
So it's a great question. We're migrating from the old model of fee for service to a model of population health, where you care for patients in terms of their overall well-being, and hospitals are no longer paid to do more and more work on patients or see more and more patients or higher volume. They're paid for caring for the total needs of the patient. And that's what UVM is doing. That's what we're doing. That's what a number of hospitals, actually all the hospitals in the state, are working together under a new payment plan, a model. It's under what's called an accountable care organization, it's called an ACO. And we're negotiating with both the state of Vermont and the federal government to go towards a pilot program here. We'd be the second state in the country to have it. Maryland's the first. And you're getting paid under a different methodology.
So you would get a block of money, let's say it's $1 million, obviously it need to be more than that, rather than be paying on all the individual patient records that you send for reimbursement. But you'll be given a block of money, and that block of money you are to use to keep patients healthy.
You'll be paid, that's correct, Don. You'll be paid on the number of patients you're caring for, a number of people. That's called covered lives in healthcare terms. And so if you take make a simple example, our hospital may be covering the people in Bennington County, and there's 38,000 people in Bennington County. In theory, under this model, you get paid a lump sum of money to care for those patients.
Well, how intrusive will you have to be then to really enforce keeping your patients healthy? Meaning, I'm using myself. Let's say I've been told by the healthcare provider I need to lose weight, but I don't lose weight. I'll stop eating the potatoes, but I'll eat the chocolate cake and the ice cream. If that's the case, then will I not be seen then because I am not being compliant?
No,
therefore you're not.
You'll certainly be seen, and it's there'll be suggested guidelines that physicians and nutritionists and other healthcare practitioners will talk to patients about. You can't force them, but you can encourage them.
But the thing is, at what point will encouragement cross over to enforcing? Because I just used weight as an example. What if you have smokers, you have people who excessive drinking, who have lifestyles that...
Well, this ends up moving a little bit towards an insurance product model, and basically you cover your risk over a broader population base. That's why it's important the hospitals are all working together to try to have this model include everybody in the state, and if you can do that, you spread your risk over a much broader area.
Right,
so if Don Keelan is not following the guidelines, maybe there's a patient like a David Meiselman who is following, and basically you balance the two patients out.
We can talk about this philosophy quite a bit, but one other point about it, and that is when you're reaching out to keep the community healthier, and you're going to be making major efforts not only with this, the ACO, is it?
Yes.
But also with your satellite, not satellite offices, but your clinics and your medical homes, I would gather, that's another term I've heard used. If you're keeping everyone healthy and not being able, and therefore they don't need to have a hospital. I mean, it sounds like you're working a contra. You're keeping your I'm going to say your customers, but they're really your patients, really healthy. So we don't need to come to the hospital. Thank God.
Well, I'll go back to my example where we at one point we had 180 patients in our hospital. Now we're running 45. Healthcare is changing. the centerpiece has always been the hospital. I believe in the future the centerpiece may not be the hospital. It's going to be how we connect.
That's interesting.
How we connect our providers to our community, and there'll be a lot more care at home. There'll be a lot more care in the physician offices. So we may need a smaller hospital, but the hospital we need is going to have to be very high tech. It's going to have to be connected to other centers, and so the model that we're used to now is going to look, and as David just said earlier, very different than what we have right now.
So the capital campaign that you're mentioning is going to take into consideration.
Absolutely.
I mean, it's really looking into the future.
Yeah.
Because as you and I both know, we're affiliated with a hospital in Poughkeepsie that built a large med-surg unit of $38 million back in 1980. Only to find out 3 years later, med-surg, the patients weren't there.
So anything we do in a capital campaign will be talking about the health system, and it won't be focusing just on the hospital. It's going to, the centerpiece, actually, the first phase of our Vision 2020 is the creation of primary care centers. Mm-hmm. We're doing that right now.
Yeah.
And that's going to me, that is the critical piece of our strategy, is the outreach piece. What we don't want to do is overbuild a hospital and overbuild and make investments that we won't see the appropriate return on those investments for the health care of the community. So we have to make sure we're investing our dollars wisely, and that's going to be investing in community health, in technology, in information technology as key pieces of the healthcare system of the future.
Yeah, we're spending our resources and our time and our energy on understanding the future of medicine and how best can we serve the community in that context. Mm-hmm. We're not bucking the system. We understand where it has to go. It's economic driven. We know where the government wants this to go, but we don't want to reduce the quality of care. So we're trying to balance, how do we keep the quality of care as good as it is, if not better, but at the same time do it in a way that is economically feasible. That's the vision I was referring to before about Tom, and that's why the affiliation with Dartmouth is a plus for us, because it enables us to do things in that direction that we might not otherwise be able to do.
You know, recently, Don, just to follow up on David's comments, the hospital was recognized by Medicare, which is the biggest payer in the country, for its value program. And they rank all the hospitals throughout the country on a value index, and values based on cost of care, outcomes, patient satisfaction, and patient safety. You know, little SVMC in Bennington, Vermont, scored the highest of any hospital in all of northern New England, in all 3 states, on the value index. So we're focusing on what David just said in terms of making sure that we provide the right type of care at the right place, at the right price, with the right outcomes. And I think hospitals, to be successful in the future, have to focus on that. And that may not be care in your hospital. That could be care away from your hospital.
I asked earlier about recruiting board doctors and nurses, and as chair of the board, do you find it difficult getting board members to serve on a hospital board? And given having been on 15 years, it's one of the most complex nonprofits you could possibly serve on as a board member, not to mention working in one.
Well, but, years ago, serving on a hospital board was a fun thing to do. You would come and you would see your friends every couple of months, and you'd have a lunch and you'd go home. It's not that way anymore. This is not your father's hospital board. It's work now, and it takes a different person who wants to give of themselves to be on a board. There's absolutely no remuneration, no compensation. I do thank them, but it's work. And so we have our meetings. We take it very seriously. It's a big responsibility to take care of the patients in the community. And we spend a lot of time talking about how do we improve our hospital, how do we maintain quality of care, and how do we do it in an economically feasible way. But if you look at our board, we have a board that's made up of doctors and attorneys, professional educators, financial people. We have a bank president. We have a terrific group of people who give of themselves totally unselfishly, who come to our meetings, they attend, they read the materials, and there are a lot of materials to read, as you know, and they come to the meetings prepared, ready to work, making important decisions. I'm very, very thankful to have the board as we have it, and I'm proud to be a member of the board.
Just so my viewers know, I have with me David Meiselman, Chair of the Board of Southwestern Vermont Healthcare, along with Tom D., the CEO and President. Let me just change the where we're heading. In January, the legislature is going to convene, and one of the major topics they're going to be taking up is the legalization of recreational marijuana in Vermont. It's going to be quite controversial. Obviously, there's several states that have it now, and we're watching what's going on out there. Has the hospital taken a position as to we should have this or not have this?
We haven't taken a position yet, but what we are doing is we're going to have I think a spirited discussion at our medical staff leadership level to talk about that, to see if if we should take a formal position. We haven't taken it up yet at the board level. I certainly have my own feelings about it, and somewhat being on.
Excuse me, you want to share those feelings?
Well, well, again.
You think he's going to get off?
No, I was going to talk about it. No, not at all. I find it distressing, to be honest, that we're looking in this state to potentially make this a legal substance. We see the impact of illegal drugs every day in our hospital, every day in our emergency room, every day in our outreach clinics, every day up in our OB service where more and more moms come in addicted to drugs. I mean, I personally think that marijuana is a gateway drug to
especially among young people.
Among young people. And today's marijuana is not the marijuana of 25 years ago. It's a very different, much more potent marijuana. I'm on the Vermont Business Roundtable. We just had a board retreat. We just had a very active discussion about this topic. And I know some people are talking about this becoming an economic driver for the state. Again, I think from a healthcare standpoint, I think it's very wrong. And I would encourage our physicians as the medical leaders to take a position on this.
So you're going to be suggesting to the board that the board take a position?
I'm going to be suggesting that the medical staff take a position.
Okay.
And when medical staff takes positions on topics, it comes to the board for their review.
You're part of a whole hospital system here in Vermont, meaning when I say a system, you have other hospitals that are part of an organization. For lack of a better word, I'm going to call it a trade organization. Has the rest of the hospital, have your fellow CEOs taken a position on this as a group? I know the roundtable. What's the roundtable's position, by the way?
They don't take a position.
They don't take a position.
No, they don't take positions on it. They had a very robust, spirited discussion on it, but they don't take official positions on it. And I'm the chairman this year of next couple of years of Vermont Hospital and Health Association. They have not yet taken a position on it either. I'm not sure we will or not, but I would encourage us to take a position on it. Mm-hmm. I think it's important. The same, in my opinion, the medical society should take a position on this. This something affects a lot of people in this state, and we're in a sense. We're almost at ground zero in our southern Vermont region. We're seeing the effects of the drug trade, and we're seeing how it's impacting our communities. And I think this continues a slippery slope in the wrong direction.
That leads me into, and you mentioned a little bit of it, what you're seeing in some of the units within the hospital, and so much of this impacts mental health. Whether they're drug users, opiate users, or marijuana, or they're abusing it. And I'm really referring to the young adults and so forth. What is a hospital doing in the area of mental health? Because it's no secret that here in Southwestern Vermont, and actually throughout the state, there is a real shortage of good mental health.
Yeah.
To the point where it was just recently reported in the newspapers where Senator Sears, our local senator, together with 9 other legislators, went to Springfield Prison, and I believe something like 60 to 80% of the population in the prison are there because of they lack mental health, and they would not, and put it this way, they would not be in the prison, Springfield State Prison, if we had mental health facilities. I mean, that's quite an indictment.
Well, a couple of
And
things.
I'm not indicting the hospital.
No, a couple of things too. And I mean, it's a real challenging problem. On any given day, and I could go back to my hospital today and look at this, 1/3 of our patients who are in the hospital for medical issues have some type of mental health comorbidities. So it's pervasive.
1/3.
1/3 on any given day. And this has been borne out on a number of studies we've been doing. The other fact is we are not a licensed mental health provider. So that's a challenge. I mean, we're a licensed medical acute care provider. We're not licensed to provide mental health services. There's a few hospitals in the state that are. So with us not having a license, we're limited as to what we can do. My goal is to create some partnerships with other institutions that are licensed that can provide services to us. And one example, one could be Dartmouth Hitchcock. There's challenges on mental health crossing the state line, so it's something we have to deal with. But another one is the Brattleboro Retreat. We're in discussions with them right now to see how they can potentially bring services that can be embedded in our primary care offices.
But
So-
Tom, if I can interrupt you
Yeah.
on this, if in fact you have 1/3 on any given day of patients, and you recognize that even if they're not in the hospital, it's in the community, the greater community here. If in fact there's a market for this, why wouldn't you seek out to become licensed?
It's because it's a very tightly regulated service in this state, even more so than where I came from in New York. And my sense is we would not get approved the state is not looking to approve additional acute care providers for mental health services. Their system is based on somewhat a spoken hub system where you have a main hospital doing that's a state hospital, and you have the retreat, and you have two or three other community hospitals. Rutland is one of them that's providing services to the population. I don't think we would get approved for it. So I think if we're not going to get approved, we should work with other organizations that are approved and that can bring services to us.
Don, can I just add that
Sure.
you've touched upon something here that's really important. The mental health crisis is not confined to Bennington or Vermont.
No.
It's a national issue. And while the government gives lip service to it, they don't put the resources into addressing the problem. I don't know the statistics across the country, but I would venture to guess that the statistics that we've been referring to here are probably not much different elsewhere in the country. So that's an issue that is going on throughout the country. There's a tremendous amount of stress and pressure upon people these days. People recognize that there are mental health problems going on in their community, but there doesn't seem to be the resources and the facilities dedicated and devoted to addressing the issue. So I think the issues that we're talking about here in our community are emblematic of what's going on in the country, and it's going to have to be dealt with sooner or later.
But why wouldn't, going back to Tom's point about the state taking, as we say, occupying the field here and not allowing
Money.
Is it money? Because
I think
because I'm going to mention, you mentioned the state facility, which is a brand new facility up in, is it Berlin?
Berlin.
Which they just spent opening it last year with about $30 million for 25 certified beds, of which now a fourth or a fifth have been closed down because they do not have the qualified nursing staff. So the state has literally closed down a fourth or a fifth of the hospital, the 25-bed hospital, because they can't staff it, and that's on the record. And if this is the state's way of running mental health. Why wouldn't you then, because of the high quality of service that you've been providing, and now the connection with working with Dartmouth, why wouldn't you just take the lead? Look, we have a need here. We have, we think we have working with Dartmouth have the professionals. We're gonna change this whole field here and take.
Well,
is it money?
Because hospitals can't work unilaterally. I mean, that's the first answer, because this is a very regulated state. The Green Mountain Care Board has overall jurisdiction as well as the Department of Mental Health. We did a step in the last year on our own because we could do this. Mm-hmm. We opened up emergency crisis area in our ER where we are providing emergency treatment, and then we are stabilizing and looking to transfer patients who need longer-term acute psychiatric help. It's a 3-bedded unit. It's been open for about a year. It's a Band-Aid to a problem, but it's a step in the right direction. At one point, the hospital did run a mental health unit. This is before my time and David's time. We had a 10-bedded unit. Hospital lost a couple $1 million per year on that unit because it's under reimbursed by the state. Not unusual, happens all the time. Mm-hmm. So the hospital had to close it. If I went back today to try to get that reopened, I'd never get it. It would never be approved.
Even if there's a demand here for it?
There's
a big demand.
The state's feelings is through their system, they're addressing the demand.
But they really aren't.
But that's. And
I can say that.
And this is certainly it's a controversy, Don. It's statewide, and this is not a Bennington issue. This is statewide, and so at least what we can control is our practices, and if we can start to embed psychiatrists in our practices to help work side by side with primary care physicians, that starts to help address the problem.
Because you're seeing, in addition to the mental health, you're also seeing, and you mentioned it earlier to some degree, overdosing on opiates mm-hmm. that are coming through either your emergency room or, and unfortunately, our neighboring state, where Dartmouth is located, they're heading to having 400 deaths this year. Mm. They had 358 last year of overdoses, mm-hmm. And now this year they're well ahead of that, and do you see more? Are you seeing more and more of this?
We are seeing more of it. Just last week we opened up an outpatient center with United Counseling Services (UCS) in Bennington to help address this, located in their building. I think that's another Band-Aid that will help. I think we have to look for a more intensive opiate treatment center, and we're working right now to do that. And I believe in the next 12 to 18 months, we'll be able to announce another level of service that we don't have in our community, which I believe we need. And this is going to be providers working together with the help of the state to get these up and running.
But I think there's a bit of conflict with the state, and obviously I can say that a little more freely than you can probably, but the thing is, and I think it was an eye-opener for Dick Sears, Senator Sears, when he saw that so many of the prisoners, and this is just one prison, in Springfield, are really there because we have no housing for them for mental health. So what we do is we house them in our prisons. Mm-hmm. And but getting back to the drug issue, the opiate issues, the President Obama, has come out recently and is asking or requesting or demanding that the medical community do something about the way in which it issues prescriptions. Because many of the people in drug enforcement and so forth really feel that a lot of the origin of opiate addiction and so forth had its origins in the medical community. Yeah. Am I overstating that?
I think, to tell you the truth, it's probably a little bit of a cop-out. There's a piece of the problem is in the medical side, but it's a very societal issue. And I will say that the head of our emergency room, Dr. Adam Cohen, led a statewide coalition to come up with guidelines for prescribing opiates for the hospital's emergency rooms. And that just came out in the last 12 months, and with a lot of very positive reaction too. So I think we're all trying to address this. This is a complicated, multifaceted problem, and clearly there's not enough money in the system to address this problem too. So it's one which we're challenged with. We're going to continue to try to do a better job, but right now I'm not happy with how the system is in this whole state.
Yeah, from the doctor's point of view, we all know physicians. Physicians are not the group of people that liberally hand out narcotic prescriptions. Every doctor I've ever met, known, represented, has been very strict in terms of writing prescriptions for narcotic medications. I think there are very few doctors in the country that liberally give these out. When you see a patient in pain, you feel an obligation as a doctor to help the patient. So I think as Tom said, there are a lot of different components to this, but what you see coming from the federal government, what I see coming from the federal government, is every recommendation they make has really one goal in mind, and that's to cut back on the cost of providing medical care. Whether it's less mastectomies, it's less prostate exams, it's you don't need the mammograms, you don't need so many pain-killing medications. Everything is about spending less money, and they're going to wherever they can go to see where they can save money.
We're almost out of time. And I'd like to ask one quick question, one question, maybe a short answer if you can, and that is, I'll ask you first, if you had one thing to work on at the hospital, what would that be? If you had the luxury of only having to work on one thing.
Well, for me, my major concern, and I mentioned it before, is to make sure this hospital is in this community far into the future, providing the best quality care that's possible. Okay. That's my point.
And Tom, as the CEO, you got all kinds of things you can, every day you got to work on. If you had the luxury of working on one item, what would that be?
Probably to focus on the development of our primary care system. I think that's where there's a huge need and opportunity, and if we can make that right, I think it helps to address a lot of the other problems in our health system here.
I want to thank both of you for being here today. You can see how the hour went by like a shot. And thank you, David, for volunteering your time. And I know it's quite a bit of time. And you and your fellow board members for allowing us to have a hospital and giving guidance to the staff and to the administration and to the medical community.
Thank you.
Tom, I want to thank you for coming over here from New York and helping us at a critical time in bringing the hospital to the next level.
Well, I appreciate that.
Thanks, Don.
Thank you.
We appreciate you.
Thank you for watching us today, and I hope you all have a wonderful day. I'm Don Keelan. This is Truth of the Matter.